Hello and welcome everybody to this month's monthly Lunch and Learn with the Midwest Concussion Clinic. My name is Matt. I'm the owner of the virtual Midwest Concussion Clinic, and this is our third installment of the monthly Lunch and Learn, where this week we're going to dive into what is a concussion. We're going to talk a little bit more about the complexities of the injury, dive a little bit into brain anatomy, a little bit into physiology, but the idea is I want to get a little bit more of a deep understanding of what a concussion really is and what kind of all goes into it. As always, thank you guys so much for watching and listening and supporting this clinic that we've built. If you'd like to get more information, you'd like to follow along, you can go through our social media channels. We're on Instagram, X, and TikTok at MW Concussion. On Facebook and here on YouTube, we are at Midwest Concussion Clinic. We have videos and information graphics that come out, patient testimonials, and the idea is we want to provide a service that outlines concussion education and provides motivation for concussion recovery for those that need it. Like I talked about this week, the topic for our monthly Lunch and Learn is concussion. Got the deeper dive into what concussions really are. They are a very common but complex injury overall. So by bringing in a new light or kind of shedding some light on the concussion itself, we want to kind of give you an overview on basic brain anatomy. Go through the different temporal lobes, go ahead and talk about kind of a basic overview of what each individual lobe is responsible for. We're not going to dive too deep into the anatomy side of things because the brain is very, very complex. So I want to give just a basic kind of overview on structures, an overview on kind of what areas of the brain that we're talking about that get involved post-concussion. The second thing that we're going to dive into is we're going to dive into the physiology of concussions itself. We're going to talk about the excitatory phase, what happens to the neurons, kind of give you an overview of what the neural network really is, and talk about kind of everything from a molecular level or microbiology level that happens once a concussion is sustained. Then we're going to dive into the three separate components needed for a concussion diagnosis. Not every headache's a concussion. Not every concussion has a headache in particular. So we're going to dive into what three components are needed to diagnose a concussion overall. And then we're going to wrap up talking about some common symptoms of concussions and some of the more uncommon symptoms that may be associated with the injury for those that are trying to go through the evaluation side and trying to figure out whether or not you've sustained a concussion or whether or not we need to make that referral to get a further evaluation done. Following the lecture today or the webinar today, if you have any questions that pop up, feel free to reach out on our social media accounts. You can also reach me at matt@mwconcussion.com via email. I am more than welcome to answer any questions and more than happy to help out. Again, the sole purpose of me doing these webinars is to help anybody that has questions, and it's to help kind of spread concussion education and awareness overall. Without further ado, let's just kind of dive into the basic brain anatomy overview. Okay, the brain is the most complex organ that we have in the body. One of my running jokes in the clinic is, it's the only thing that you can't get a new one of. You can get new knees and ankles, you can get new elbows, toes, you can get a new heart and lungs. It's harder to get those things, but you can get them. The brain is the only thing that we have from the very beginning conception and very beginning parts of our fetal development all the way through our passing. So it's something that we need to take care of. That being said, it is very, very, very complex. So we're going to try to go through some of the basics here. So this is just a kind of general overview of what the brain is. The brain is broken down into 5 different areas that we're going to talk about during today's conversation. If we're looking at the brain here on the image, the front part of the brain is on the left, the back part of the brain is on the right. Okay, so looking at the purple section, that is our frontal lobe. It is all kind of in the very front part of the brain. From a basic perspective, this is where a lot of your executive function comes from. A lot of decision making, your ability to make rapid changes and answer questions. It's your ability to kind of go through and make decisions on a day-to-day basis. It's also where a lot of our personality and emotional regulation kind of comes from. Back in the old West days, they talked about doing frontal lobotomies, which is where they would drive a spike through the front part of the brain to kind of kill the brain tissue to fix people that had schizophrenia or somebody who had a personality disorder. It's because this part of the brain is primarily in charge of our emotional regulation. It's not the only place that we're in charge of emotional regulation, but it's one of the primary areas. The frontal lobe is also in charge of our judgment and our voluntary movement, right? So making a judgment decision. Should I do this? Should I not do this? What should I have for lunch or dinner? Should I wear this color shirt or that color shirt? The frontal lobe kind of is in the beginning stages of the judgment side and our voluntary movement. So the voluntary movement aspect of things is, should I walk? Should I get up? It's more that decision-making aspect of the movement, not necessarily the coordination of the movement itself, but more of the, should I make these voluntary movements happen? And then the final major primary function of the frontal lobe is memory storage, converting things into short-term memory, taking what we're learning and trying to put it in a situation or in a place that we can use it long-term. Shifting gears to the little yellow section at the top, the parietal lobe sits up on the top part on both sides. One thing that I didn't mention initially, looking at the brain, this is a side view of the brain. If we're looking at the brain on the front, you'll have a right and a left parietal lobe. You'll have a major frontal lobe. You'll have a left and right temporal lobe. You'll have two sides to the brain itself. Okay, so this is just looking at the one side, and in particular, this is looking at the left side of the brain. The parietal lobe, it's in charge of primary sensory integration. What that means is it's in charge of kind of our touch sensation, our feeling, our smell, our sense of sight and vision. It's a processing center for integrating what those sensory input really are. Not necessarily what we're seeing, but how we perceive that sight or how we perceive that visual memory or emotional kind of thought or the general overview of sensory processing and sensory integration. It's also in charge of our spatial awareness. Not that everybody does it, or really that I've done it, but if you've ever tried to close your eyes and walk through your room and figure out how much of your day you can really get through with your eyes closed, a lot of that is spatial awareness. It's the ability to know where we are moving through our environment. A lot of times post-concussion, I'll get patients that talk about feeling lost or running into door frames or hitting their knees on coffee tables more often than normal. And that has a lot to do with the spatial awareness and some disruption in the parietal lobe. The third thing that we look at with the parietal lobe is motor control. So more the ability to control our motion and our ability to control voluntary movements. So we talked about voluntary movement happens in the frontal lobe, making that decision on what we're doing. The parietal lobe has more of a control on the voluntary motor control, reacting to sensory input, reacting to image input. And then the final thing that the parietal lobe, in the big picture that we're going to talk about, is language processing. It's the part of the brain that interprets what's being said to us and kind of how we perceive that language coming in. Okay, it doesn't necessarily have much to do with, can I learn Spanish? Can I learn German? Can I learn English? It has more to do with how we process that language that's being spoken or that language that's being brought in. Shifting to the lower part, that pink kind of pale squishy part is the temporal lobe, and it sits kind of down low in the brain just above our ears, and its primary function is auditory processing. It's thinking, or it's taking what we're hearing and kind of making a decision on what's being said, what's being listened to, what's coming in, and then converting that to verbal memory, right? If I'm carrying on a conversation with somebody and they tell me, hey, I need you to remember this, or you're reading something and you're like, oh, okay, I don't need to write that down. I can read this or I can kind of remember it. The temporal lobe is in charge of that verbal memory component. It's also another portion of our emotional processing, not necessarily regulating the emotion, but processing how we feel about a given situation or processing how we feel of any given time. And then the final thing that the temporal lobe major component is involved with speech patterns. So it's involved in that link between what we think in our head and what we say out loud. It can be a component of why people will struggle with difficulty with language processing or difficulty with, I can tell you everything you need to know about a pen. I can tell you what it does. I can tell you that I need one, but I may not be able to say the word pen. It's part of that speech processing and that speech portion of the temporal lobe's kind of involvement. On the back side, we got the blue occipital lobe. That occipital lobe sits on the back part of the brain, and its primary processing is visual recognition and visual processing. That is the visual center of the brain, which is why when most people hit the back of their head, they will complain of, like, my vision goes blurry, or I see stars, or I have some kind of visual disruption, whether it's double vision or light sensitivity, because the disruption of the visual processing centers of the brain that happen in the back. That's also why we see people that hit the back part of their head will struggle a lot more with kind of visual motion sensitivity and some of the visual disruption that occurs. It's also where we go through and kind of store our facial recognition. It's happened to most people. It happens to me a lot. I recognize people, but I may not remember why I know them. It's, you're talking to somebody, it's like, hey, I've seen that face before. Like, I know who you are, but I don't really know who you are. That's part of that facial recognition component of the brain, of that occipital lobe. And then it's also another part of our visual memory component. Hey, if I look at these 4 numbers, can I remember what these 4 numbers are? Can I remember where these things are on a screen? If you're somebody who's gone through concussion rehab with me, it is one of the things that I work on quite a bit with the numbers on the different parts of the video screen, with the different parts of the whiteboard. It is something that we work a lot on because it's a major component of kind of restoring the occipital lobe to its normal function. And then rounding out the brain anatomy component of the major lobes, we have the cerebellum in that green portion down at the bottom. The cerebellum is our coordinated movement control center. It is the ability to walk and talk and chew gum at the same time. We talk a lot about dual tasking and the ability to do things while standing or marching in place or walking around the room. This is working on cerebellum function. This is also the primary center of the brain that deals and controls with our, deals with in the control of our balance aspect and our motor movement. So our walking, our ambulation, our running, our jumping, our twisting. The cerebellum is kind of what I call the key to concussion rehab. We need to make sure that we're integrating the different parts of these lobes and the different deficits that we have with cerebellum function and cerebellum coordination control. And we need to make sure that we're working on kind of reestablishing the cerebellum to its primary function and its normal processing speed. The next part of the brain anatomy that I want to kind of jump into is a cross-section of the brain again that looks at the different areas. On the top part of the brain, there is the blood-brain barrier. It is the little thin blue line that runs between the outer cortex of the brain, which is the squishy pink part that's labeled, and the skull itself. The blood-brain barrier acts as a barrier for protection to the brain. It also carries nutrients that we'll get into here in just a minute. The pink part of the brain that's outlined is called the cortex. The cortex is kind of the outer portion of the brain that kind of covers the inside portion, which is highlighted with the brackets, with the midbrain, the brainstem, the medulla, the different areas of the hippocampus, the different areas of the inside portion of the brain, which is what I like to describe is where you are in terms of kind of keeping you functioning, keeping you coordinated, keeping you moving. That midbrain, that kind of brainstem is in terms of regulating a lot of different things in brain health. And that cortex job is to kind of protect the midbrain to an extent. It does a lot more than that, but it protects the inside portion of the brain, which is where essentially we differentiate between individual people. Why does talking about the anatomy of the brain matter when we start looking at concussions? My primary focus with going through a basic overview of anatomy is, number one, it gives you a general understanding of where the disruption has occurred in the electrical signal that we'll get into inside of the brain based on what symptoms a patient is presenting with. If I have a patient that's coming in telling me they're struggling with visual processing, they're struggling with blurred vision or double vision, I know that there has been some form of disruption to the electrical signals inside the occipital region or the occipital lobe inside the brain. If I have somebody who's struggling with executive function and processing, I know that there's been some electrical signal disruption to the frontal lobe and the front part of the brain. One of the common misconceptions we get with a lot of patients that I deal with is getting hit in the head. It does not matter the hit location for the most part. Most people will come in saying, I got hit on the left side. That's why I have the headache on the left side, right? Not necessarily. Once the force comes into the brain, it moves around the brain depending on whether it's a linear force or a rotational force. It moves through the brain and causes disruption in the different lobes of the brain. Based on those different lobe disruptions, we have the different symptoms. So I have to have a basic understanding of brain anatomy in order to be effective in communicating why certain things are happening inside the brain post-concussion. The second reason that I talk about brain anatomy when I start talking about what a concussion really is because it gives a patient, it gives a clinician a total understanding of kind of what the totality of the injury really is. We start looking at the complexity of the injury. It's not easy, it's not simple, it's not fast. Concussions are a very complex injury that the more research that comes out, the more we're actually learning about what concussions really are. And this may totally evolve the more understanding and the more research that gets passed along in the kind of big picture of concussion research and concussion diagnosis and recovery. So now that we've talked about the basic anatomy of it, let's talk a little bit more about the physiology of a concussion itself. So when we start looking at concussions as a whole, they are very, very kind of simple but complex at the same time. We know basic structures, we know basic anatomy, but what is happening at the microbiology and the cellular level that's causing this injury to occur? So most of us have seen this GIF or this video of the analogy is your brain is like sitting in a bowl of jello. Okay, so this analogy is the skull is a bowl of jello, the brain is the jello inside. If we hit the bowl, the jello moves. This video has been shown for years when we're trying to explain what happens with a concussion. When the skull gets hit in the forehead, the brain slams the front part of the skull, we get an acceleration, deceleration injury, and as it kind of jellies around, it hits the different ridges of the skull, and depending on where the impact sites were what kind of symptoms or damage that we dealt with. The thing that I don't like about this video is it misses the second half of the skull. The second half of the skull has fluid and pressure and keeps the brain from slamming around like we used to tell people. Doesn't mean that there isn't enough force generated with certain injuries that we get the traditional coup and contra coup injury, which coup is just the brain hitting the front part of the skull in this situation, and the contra coup is the brain hitting the back part of the skull. But the idea behind the intracranial pressure, the blood-brain barrier, the idea behind those is it keeps the brain from not necessarily slamming around inside the brain or inside the skull like we used to tell people. It's more of a, kind of controlled environment than this GIF would like to tell you or would like to lead you to believe. That's, again, another one of those things that's shown us a kind of update on concussion research and what's changed and how we explain what concussions are. It's an image that I talk about with all of my patients that come in, but it's not necessarily what is truly or traditionally happening inside the brain. So when we look at kind of what happens, just like you have a heartbeat, you have a brain beat that is totally unique to you. Yours is completely different than anybody else's. Your brain goes as fast or as slow as God or medication intended your brain to go. ADD, ADHD, autism, they are changes to the electrical signals inside the brain and the electrical processing parts of the brain. When the brain is working harmoniously. Now, this again is kind of taking things down in complexity because of the idea behind neuroscience is one of the most complex topics that we can talk about. So kind of bringing it down in terms of complexity, the brain beat itself works best when the brain is in harmony. The brain is working at a consistent speed throughout the different lobes, throughout the different cortexes. The electrical signals are being passed from the back part of the brain to the front part of the brain pretty consistently in terms of speed, and everybody is on the same page. But that brain beat is carrying the electrical impulses around the brain based on what's being processed. One of the things that I talk about with my patients is when I'm seeing something, let's talk about visual processing. Once I see something, the eyes will convert the electrical signal down the retina to the back part of the brain. The occipital lobe will then interpret what is being seen, and then it'll pass it through the neural network, depending on what the information is and what we need to do with it. So one of the things that I talk about, we see it, we identify it, we figure out what we need to do with it, we make a decision on what we're going to do with it, and then our body and the cerebellum will make decisions and make things happen. Okay? When we start looking at the electrical signals inside the brain, we have an estimated 100 billion neurons inside the fully developed adult brain at any given time. Okay, that 100 billion neurons, they connect together to create up over 100 trillion neural connections. If we think about it, there are anywhere from 2 to 3 trillion stars in the Milky Way galaxy that we can observe at any given time with the naked eye. Okay, there are 100 trillion neural connections right here, and there's only 2 trillion stars in the sky. That is a ton that's going on inside a small capsule, right? That is a massive amount of an electrical signal being passed around, and it all works very easily, very coordinated to kind of carry those signals around throughout, our day-to-day function. If we look at that neural network, those neurons that carry it down, we need to break down what's actually happening with each one of those individual 100 billion neurons, okay? On the diagram here, we've got a basic neuron. Up at the top, the brackets around it, you've got the cell body, the nucleus, the body of that neuron. That's where most of the processing signals are sent. That's where most of the different electrolytes that we'll talk about here in a minute go and are kind of stored and kind of pass through. The bracketed yellow tail is what's called the axon body. That's where the electrical signals will travel down. And in this diagram, the actual yellow is what we call myelination or myelin. It is a insulated sheath that gets put around neurons. As we get older and as the brain develops, the body will produce myelin to wrap around those neurons to kind of insulate it and speed up the electrical signal processing that happens. And then the little tails that are down by my picture are the axon terminal. That's the final part of that axon where those electrical signals will travel and be passed to the connecting axon body cell bodies. So if we look at the neurons, the yellow arrows that are happening at the top part of the screen, the electrical signal is interpreted by the dendrites that are down on the very bottom of the axon cell body. That neuron cell body, the dendrites will interpret the electrical signal from another neuron. It'll pass it through the cell body. It'll come down the axon body through those myelin sheaths down to the axon terminal before being sent off to another connecting neuron. Those axon terminals may integrate multiple dendrites, multiple different axons. It may only integrate one axon depending on the complexity of that neural network or where we're at in terms of the neural chain. So that kind of concept, if we break it down in one part, it happens relatively smoothly, right? The dendrites will interpret the signal from the other neuron, send it down the cell body, down the axon, down to the axon terminal, and out. And it processes over and over and over and over again. Now, if we think about those axon terminals connect to other axon neuron bodies, and those neuron dendrites create up over 100 trillion neural connections. A lot of that processing is going on all at the same time. So when we start looking at the idea behind the neural network, those neurons carrying the electrical signal are what we kind of have to pay attention to when we start talking about what is actually truly happening during a concussion. A concussion or a hit to the head or body, again, not necessarily a directly hit to the head, a rapid jolt or a rapid movement of the body, hitting a shoulder or head on a floor or on a wall, can cause a shearing force that occurs on the inside portion of the brain. One of the kind of visual representations that I give is you've got the cortex. You've got the outer portion of the brain. Its job is kind of to carry electrical signals around, processing. We went over the different parts of the lobes and the different kind of parts of the processing center. But you have the cortex, and then you have the midbrain. The midbrain protects the cortex. The cortex protects the midbrain. And what happens is when that cortex goes through its day-to-day movement, the brain does not move inside the skull like we used to tell people, but the cortex will shift and shear back and forth. So if I have somebody who comes and gets hit in the forehead, right? If I have that hit to the forehead, that cortex will kind of shift back and forth, causing a shearing force. That shearing force will take those neurons and make them slide back and forth. You get a big enough hit, a big enough movement, a big enough force, that hit will cause those neurons to shear, and it will break those neural connections. So now all of a sudden those neural connections are broken apart. When those neural connections get broken, they fire their electrical signals. Now, what causes that firing of the electrical signals? Again, we're going down into the very, very microbiological level, okay? If we start looking at what happens once the shearing force occurs, we have a kind of neurometabolic change that occurs inside the axon structure itself. Potassium starts to leak out of the axon, right? So potassium's been stored in the axon, or the cell body of the neuron. It starts to leak out of the cell body, and as it's leaking out, calcium will come into the cell in the axon and neural body, and it will come into the cell, triggering the brain or triggering the neuron itself to release an electrolyte called glutamate. Glutamate will be released out into the kind of the certain cell transmitter areas randomly. So that it'll start to, instead of coming out fluidly to carry that, to continue to progress that electrical signal coming down, glutamate will start to get released in sporadic positions, sporadic timing, randomly, to create what's called the excitatory phase of the neuron, which will make it fire in a sporadic fashion. If we think about kind of like a neon sign, right? A neon sign, when it starts to go bad, will start to flicker. It'll start to go in and out, turn on and off. The similar situation happens once we have that neuron shearing force that causes this neurometabolic cascade or neurometabolic processing issue inside each individual neuron. So as that neuron kind of releases glutamate, it hits the excitatory phase, it starts to fire off and on at random times and random intervals. That causes the brain to go, okay, something's not right here, and it will physically slow itself down while it tries to heal. When the brain slows itself down, the rest of the body will try to speed the brain back up. And that's where a lot of the patients will start to notice symptoms come from. Is the body will try to essentially pick up some of the slack. The human body is a perfect check and balance system. Once one thing slows down, we do something to make something speed up. The similar process that happens inside of a concussion. Once the brain goes through its excitatory phase, it fires all its neurons at the same time. The brain goes, uh-oh, something's not right here. And it slows itself down while it tries to fix and reconnect neural processing, tries to regulate the hormone cycle that's going on inside the brain, causing that chemical disruption. Once we have that excitatory phase of that chemical disruption, the full neurometabolic cascade that occurs post-concussion is linked to ATP production. This is a graph that I use in a lot of my different webinars. It's a graph that I use to explain a lot of different things, but this is a basic overview of what the neurometabolic cascade comes to in terms of concussion, the ATP demand and production. If we look at the very beginning, that 0 to 48 hour mark, that kind of varies. Some research tells you it happens within the first 6 hours. Some research tells you it happens within the first 72 hours. For the most part, we look at a rapid influx of ATP demand that will occur within the first, 0 to 2 days. That ATP demand, there's a lot of fluctuation that occurs. When the brain goes through its excitatory phase, its injury response, its acute response phase, there's a massive demand for ATP production to kind of keep systems going, to keep the status quo. As we transition outside of that 48 hours, the body and the brain will essentially decrease its production of ATP overall. ATP is the number one cellular molecule that we have for energy. And we're not talking like, hey, I need to get up to go, to take the trash out, or I want to get up and go out and run a marathon. We're talking, do I have the energy to carry this molecule of oxygen through the bloodstream? Do I have the ATP to carry that passing of calcium and potassium in and out of the cell? So we're looking at very microscopic. The brain is the number one producer of ATP that we have overall. It's not necessarily something that we look at the big picture. It's not something that we look at it's the only producer of ATP, but it is the primary producer. When the brain gets hurt, this blue line that's coming down, it stops its production of ATP and starts to lower its overall production of ATP. As we get farther away from that injury date, the body will then start to increase its production of ATP until we get back to a point where that neurometabolic cascade has occurred and it has kind of leveled itself back out, and we have a kind of basic normal ATP production. When there's a decrease in ATP production inside the brain is also injured. So it's demanding a much higher level of ATP than it normally has. So now not only are we not producing the ATP, we are taking it from everywhere else. And that's why we get what's called an energy crisis. To patients, you're tired. Days where you feel good, you're tired. Days where you don't feel good, you're really tired. It doesn't matter how much you sleep, you feel tired. As you start to do your physical activity, like, hey, I'm starting to feel better, I'm starting to get back to my normal routines, we start to look at, now all of a sudden, I feel like I'm out of shape. Generally, it's not cardiovascular shape, right? It's not cardiovascular endurance that's the issue. It's the lack of ATP production. It's the lack of energy molecules that we have in the body, causing you to feel kind of slow and run down. The other reason we talk about the primary problem with the neurometabolic cascade is the idea behind second impact syndrome. Second impact syndrome is an event that can occur for people primarily under the age of 18, but still present for most people, that when you get hurt and you have a concussion, you sustain a second blow to the head or a second hit to the head body that causes a second energy crisis inside the body. If I'm down at that low level of energy production, that ATP production overall, and I sustain a second hit to the head, there's another rapid influx of ATP demand for a short amount of time, and then my energy levels tank production again. If the bottom of that graph is the basic ATP level that we need to carry out major body functions, and all of a sudden our ATP production drops below that level that we need to sustain life, now all of a sudden we run into a situation where vital organ systems can start to shut down. The idea behind second impact syndrome is actually fatal for a lot of people that it occurs with, which is why we spend a lot of time talking about the importance of minimizing additional hits to the head and minimizing that risk of re-injury. You notice I have now been 35 minutes into this presentation, into this production, and I have not once talked about structural injury. There very, very, very rarely is there anything that's going to show up on a structural CT scan, X-ray, MRI when it comes to a concussion, because there is no structural damage that occurs. Now, there's research, and I can argue that there's structural damage that occurs to the cells and the neuron bodies themselves, but for the sake of this argument, there is no major structural damage that occurs. If concussions were traditionally a bruise, which is what is still being taught to a lot of patients that come into our office. Yeah, they told me I bruised my brain. They told me that my bruise will get better in a couple days. They told me that my scans were normal and I should be fine. Concussions are not a bruise. They are not simple like that. The old school approach for concussion recovery is, hey, concussions will get better in 7 to 10 days. Do you know why? Because bruises tend to get better in 7 to 10 days. That is not what happens. Concussions are a disruption of the electrical signal inside the brain that causes an energy crisis inside your body, and it causes a neurometabolic cascade to occur that disrupts the speed and processing of the transmission of those electrical signals. Now, I totally get it. I totally understand why people still describe it as a bruise. It's a whole lot easier to describe to a patient in a short amount of time. If I'm dealing with insurance, I have a doctor that comes in, I can only see you for a short amount of time. I've got 30 patients today. I'm already running behind schedule. Yeah, your scans are normal. You got a bruise, you got a concussion. It'll get better in a couple days. You'll be good. And when we start looking at it, that's what happens a lot. And when we get, the difference between our office and what, other people have been through is I'm not bound by those times, right? I want to sit here and I want to explain things to you, which is why we spend so much time talking about the actual electrical signal disruption portion of concussions, not the structural damage itself, because there is no structural damage that occurs. Concussions are a disruption of the electrical signal, not a bruise, which is why they don't show up on CT scans. Now that we kind of have a basic understanding of what is going on anatomically, what's going on physiologically following a concussion, let's look at the different components that we need to actually diagnose the concussion itself. I usually break it down into 3 different components that you need to go through the actual concussion diagnosis. The first thing that we need to have is we need to have a mechanism of injury. We need to actually have a concussive event. Concussions don't spontaneously show up. You don't wake up one day with a concussion. That's not something that happens. It doesn't necessarily mean that you remember the mechanism of injury or you remember the event, but it's not something that spontaneously sitting here in my chair, I can sit here and say, oh, now I've got a concussion. That's not something that happens. We have to have a mechanism of injury. And we start talking about what the mechanism of injury is. It's a hit to the head, neck, body, or ground that causes a jolting to the brain itself. You don't necessarily have to get hit in the head. If I'm walking or I'm, playing ice hockey and I'm skating and somebody checks me and all of a sudden I get that whiplash motion, that whiplash will cause the shearing forces to occur inside the brain itself, taking those neurons and breaking those electrical signals. So just because you have somebody who says, I don't remember hitting my head during the football game, or I don't remember hitting my head on the steering wheel when I was in that car accident, just because you don't remember the mechanism of injury doesn't mean that it wasn't there. And in order to diagnose the concussion, we have to have some form of concussive event, or we have to have a mechanism of injury. The second component to a concussion diagnosis is we need to have a subjective report of symptoms. Now, I'm going to get into this in just a minute, but the subjective report of symptoms does not always occur with athletes. I'm fine. I'm good. I feel okay. I always talk about, I protect my patients in terms of I'm going to back you up and say, hey, you may not have understood what's going on. You may not have kind of known the full effect of the symptoms that you were feeling, or you may not have even known how to portray or kind of relay those symptoms to somebody when they ask you about them. But most people will report some form of a subjective symptom. Whether they try to downplay it or not, that's a different story. But we have somebody who goes through has a mechanism of injury, has a concussive event. They say, hey, I've got a headache, I'm dizzy, I got blurred vision, but I'm good. I'm fine. It's just a little headache. I always get headaches. Well, now we have a subjective symptom that's been reported following our mechanism of injury or our concussive event. The third component to a concussion diagnosis that we have to have is we have to have some form of objective findings. When we look at objective findings, there are multiple different tests that you can use. Some computer-based, some phone-based, some paper-based, some eye tracking movements. All of them are looking at what's considered normal for their age group versus what they are presenting with. Very rarely do I get somebody that comes in with a baseline test. In terms of trying to to allocate funds or allocate time, baseline testing is one of those things that's slowly starting to kind of fall to the wayside. I am one of those that said, if I have a baseline test, fantastic, wonderful, great. If I don't, that's okay too. We can figure it out. We can go through some of these objective tests and compare somebody to what normally would present versus what they are seeing based on their objective testing. In my office, I use the VOMS test, the vestibulo-ocular motor screen. I look at eye tracking and eye movement because, in my opinion, you cannot fake eye movement abnormalities. I can't fake a nystagmus. I can't fake an overshooting or an undershooting with saccades. It's not something that I can voluntarily replicate for most people. We do have those people that can go through voluntary nystagmus. We do have people that can replicate these. But for the most part, in terms of a concussion evaluation, it's not something that people are going to replicate or trying to make appear. We compare that with kind of the mechanism of injury and then the subjective reports. The reason I have the highlight around the subjective symptoms is if I have an athlete that comes in, I've seen the mechanism of injury, I've witnessed it, I've watched it happen. I had a car accident, I was in the car, I've watched it happen. If you're coming to me following a car accident, subjectively, I really don't care whether you're reporting symptoms or not. I need to go through and look at objective testing to kind of support what happened. If I have an athlete that's kind of coming in saying, hey, I'm good, I'm fine, I take their word for it, but I want to make sure that objectively we are not able to replicate or reproduce any abnormalities on testing. So when I start looking at the three components of concussion diagnosis, I need to make sure that all three of them are present, but not all three of them are present individually. If I have a mechanism of injury with no symptoms and no objective findings, I can't diagnose a concussion just based on the fact that they hit their head. If they hit their head, they come into me, they have no objective findings, they have no subjective reports, I can't diagnose a concussion that way. If I come in with somebody that objectively there's some findings that are consistent with concussion, there is some subjective reports, but they're sitting here saying, I didn't ever hit my head, I didn't rapidly move, I woke up feeling this way. I need to look at what else might be going on that's presenting with symptoms similar to what we're dealing with, not necessarily the concussion itself. If I have somebody who only comes in with subjective reports, but objectively there's nothing wrong and there's no mechanism of injury, I might need to look at psychologically what's happening or what else might be going on in terms of like a cognitive issue or a depression, anxiety, mental health problem, or something along the lines of dehydration or malnutrition. I need to look at something that's not necessarily a disruption of the electrical signals like a concussion and more what else could be going on. The reason we talk about common and uncommon symptoms with concussions is pretty easy, pretty basic, pretty standard, okay? Not everything will be the same based on each individual injury. So some special considerations, concussion symptom presentation. Everybody's symptoms will be different. And what I mean by that is not only will they be different from person to person. I've had a concussion, my friend's had a concussion, his concussion symptoms are totally different than mine. They will also have a potential to be different between each individual concussion somebody might have. When I explain this to a patient, the brain is in a totally different chemical makeup at the time that they are now versus when they got hurt 2 years ago or 5 years ago, or one that, if they get hurt again 6 years down the road. The brain and the hormone cycle and the hormone balances are totally different. The brain health is totally different at that given time compared to their previous injury or a future injury. So symptom presentation will vary from injury to injury, from person to person, from time to time. The second thing to keep in mind is symptom timing. Symptom presentation does not necessarily happen immediately. I will always defend athletes, okay? Getting into sports medicine, going into it, being an athletic trainer, the idea is at some point, sports ended for everybody. I'm an athlete at heart. I still like to think I'm an athlete, despite what I feel like when I try to do things athletic. Symptom presentation may not present right away. So if I have an athlete that comes in and says, yeah, I hit my head on the ground, I finished the game, I get to talk to them about how dangerous that is because the second impact syndrome, but I also can defend them in saying, hey, when the adrenaline is pumping, when you're in game mode, you may not understand what symptoms are present, you may not feel symptoms that are present, and you may not actually have any symptoms at all. As the adrenaline starts to wear off, that's where symptom presentation may start to line up and where symptoms may start to appear. So symptom timing is something that needs to be taken into consideration when talking to somebody. If I'm an athletic trainer or somebody on a sideline or a parent with an athlete that gets hurt during a game, the mantra, when in doubt, sit them out. Brain health is something that has to follow us our entire life. Decisions that we make about sports now will have long-term consequences, good and bad. So if I have somebody who is a middle school aged athlete, they've hit their head playing soccer and they're presenting with a little bit of dizziness, they get a headache, but they've been sick. They've had a headache all the time. They always get headaches when they play soccer. When in doubt, sit them out. If I have even a hunch that somebody may or may not be dealing with a concussion, I will always err on the side of caution, and I will always recommend to parents to err on the side of caution, as well as athletic trainers and physicians to err on the side of caution when it comes to concussion diagnosis. If you're unsure, buy yourself 24 hours. Hey, let's follow up in 24 hours. Let's see. Let's try multiple objective tests instead of one objective test. Let's try multiple subjective questionnaires. Present the questions differently. Ask the same question, but don't phrase it in terms of, do you get a headache? Are you dizzy? You sit here, it's like, hey, when you get done playing, do you feel that kind of roller coaster feeling? If I move my head really fast to the right, do I feel kind of off balance or, wavy or weird? By phrasing it like that, you can get people to admit certain things are different because they don't have the negative connotations of reporting a headache following a hit to the head. They don't want to be diagnosed with a concussion because concussions are a bad word, or they know they'll be out. Okay, so take that into consideration when going through symptom presentation and symptom timing. The third thing to take in mind is you have to take each symptom individually and as a group. Asymptomatic does not necessarily mean that a concussion hasn't occurred or that somebody or an individual is healed from their concussion. We need to make sure that those three components are back in line. We have the concussion event, we have the objective testing that's back to normal, and we have the subjective reports that are back to normal. Asymptomatic doesn't necessarily mean that the concussion has healed and that somebody is ready to return to their normal daily routines. Not every headache is always a concussion. Headaches are a very complex occurrence. We have migraines, we have dehydration, we have difficulty with visual processing. Somebody might need glasses, there might need a change to the prescription. If I have somebody who hasn't eaten, who has been sick, dehydration, lack of sleep, too much sleep, headaches are very complex. Not every headache is a concussion. So we have to make sure that we're taking that into consideration when we start looking at concussion diagnosis and concussions as a whole. Some of the common symptoms that we see with concussions, again, not necessarily all of the concussion symptoms that we deal with, but some of them are kind of the common ones. Headaches, dizziness, nausea, lightheadedness, blurred vision, double vision, light sensitivity, noise sensitivity. Those are all things that people will commonly present with. They'll commonly come in, they'll sit down in the office and they'll say, hey, look, I hit my head, I've got a headache, I'm dizzy, I'm nauseous, I feel different, something's off. Generally, those are your common ones. Your common symptoms, people will talk about some short-term memory difficulties and some balance problems. I feel off, I feel weird, I just feel kind of blah or meh. Some of the more uncommon symptoms that people will deal with that a lot of times when we're talking with patients, they don't realize until we go into the education side of things that these are actually going on. Some of the more uncommon ones that we see are personality changes. Somebody who's normally a happy-go-lucky, joyful person, now all of a sudden they're angry or they're irritable. They have rapid mood swings. They're noticing an increase in their anxiety or an increase in their depression symptoms that is uncharacteristic. Their normal anxiety triggers are out the window. Now all of a sudden I'm sitting down trying to have dinner with my family and my heart races and my blood pressure spike and I get hot and sweaty, or I struggle with temperature regulation, or I struggle with, some inability to pay attention in conversations. Those are some of the more uncommon things that occur. Long-term memory difficulties can be something that's not necessarily talked about with patients, especially car accidents. I get into a car accident. Yeah, I don't really remember the injury itself. I don't really remember what happened, but I remember everything after the injury. If we start digging in more and more into what's happened, in their childhood, what happened before the injury, do you remember what you did last week? Do you remember what you did the day before the injury? Those type of things can often get overlooked because it's not something that presents in the forefront of a patient's brain or forefront of the patient's mind. Another uncommon symptom that people will present that we see quite a bit is the sleep disruption that occurs following a concussion. Concussions will cause the fight or flight response to kick on inside the brain. That fight or flight response will struggle with regulation of our sleep-wake cycles. We see a lot of patients that will kind of brush sleep difficulties under the rug and kind of brush it off when we start talking about, hey, tell me what you're experiencing. Tell me what symptoms you're dealing with on a day-to-day basis. A lot of them won't talk about sleep right away until we start getting into the totality of the injury, the full kind of complexity of the injury itself. Then they'll start to look at, okay, yeah, now that you mention it, I have sleep problems. Or now that you mention it, my nausea has caused me not to have the same appetite or same cravings. Or I'm craving something else that normally is not something that I eat on a regular basis. Those are some of the uncommon symptoms that we see with concussions. Overall, the goal of today's webinar was to go through and kind of explain to you not only one, that the totality and the severity of the injury is much more than just a bruise. I also want you to take away that concussion symptoms are different from person to person, from injury to injury, and the concussion symptoms will vary throughout the concussion recovery. You may have a headache all the time at the beginning that becomes periodic. I was sleeping great at the beginning. Now I'm not sleeping very well at all. I didn't have any light sensitivity, but now that I'm getting into my rehab or doing more of my day-to-day routine, I'm getting a lot more light sensitivity that starts to present. Just because somebody didn't have a symptom at the beginning doesn't mean they won't experience the symptom throughout their concussion recovery. Don't be alarmed if symptoms fluctuate. You have good days and bad days. You have good headache days. You have bad headache days. You have really light sensitive days. You have really noise sensitive days. The fluidity of concussion recovery and symptom presentation is something that will occur throughout the entirety of concussion recovery. Just to wrap some things up, I hope you understand and took away from today the basic brain anatomy, the things that the brain needs to kind of go through its normal day-to-day functions, its normal day-to-day routines, the basic structure of the brain, the different types and lobes of the brain, the different physiology that occurs when the concussion hits. And the whole goal between breaking those two things down is to try to bring light into the severity of the concussion itself. It's not just a bruise. There's much more complex occurrences that are happening inside the brain during a concussion. Downplaying the severity of the injury is doing a disservice not only to the patient, but to the complexity of the injury itself. I hope that we're able to take away the three components of concussion diagnosis. We've got the mechanism of injury, the subjective reports, and the objective testing. We need all three of those to work in conjunction with each other. And then I hope you can be able to identify some of the more common and uncommon symptoms associated with concussions. It's not all headaches, dizziness, and nausea. There are a lot of different things that often get overlooked when we start talking about initial evaluations or dealing with athletes or individuals that have been involved in falls or car accidents or have presented to the emergency department or urgent care because they feel a sense of, I'm making this up, or this is in my head, this isn't really going on. I hope that those uncommon symptoms start to shed a little bit more light in terms of kind of what's actually occurring inside the brain to cause this disruption. As always, thank you so much for following along with the virtual Midwest Concussion Clinic's MCC Lunch and Learn here for April, where I covered what a concussion is, a common but complex injury. Again, my name is Matt. I am the owner and founder of the virtual Midwest Concussion Clinic. We specialize in the concussion evaluation, treatment, education, and consultation of patients of all ages, bringing work with a concussion expert, concussion treatment, all to the comfort of your home. Thank you, thank you, thank you. I can't say it enough. Thank you for tuning in. If you like this, please subscribe to our YouTube channel. If you're not yet, follow along at our different social media accounts. We're over on Twitter, Instagram, X, Instagram, TikTok at MW Concussion. We're here on Facebook and YouTube at Midwest Concussion Clinic. We got a LinkedIn page over on Midwest Concussion. Each page has a little bit of a different kind of way we present the information, but for the most part, the whole goal is to provide a concussion education and provide a service for free. That way, if you find yourself struggling or you find yourself, working through a concussion recovery or trying to find somebody to help you through your concussion journey, I pop up. As always, if you have questions, feel free to reach out. But again, my name is Matt. I am the owner and founder of Midwest Concussion Clinic. And as always, thank you for tuning in. Every third Wednesday of the month, we cover a different topic at noon Eastern here on our YouTube channel. Hope to see you again next time around. And as always, have a great day. Thank you for tuning in.